I would say the majority of people I see tend to have either migrated filler around the lip area, or the people have radius put in their jawline. They don't like it. And so then when they're biting, then they get sort of these like fins almost that are on the skin that will pop out, because it's placed too superficially. And this
Yeah.
becomes challenging because when you're talking about treating uh, fillers that we're placing correctly or in a location that the patient is not happy with, that can be challenging if we're talking about fillers that we cannot dissolve.
Welcome back to season 2 of MedSpa Mayhem. Today I'm speaking with Dr. Dahlia Rice, a board certified plastic surgeon in the Chicago area. We're talking all about dermal filler and how Dr. Rice likes to use it and how she deals with it when people come to her to correct filler that's gone wrong. I hope you enjoyed the discussion. As always, if you have questions or a story you'd like to share, or if you'd like to hear more about a topic on the podcast, please reach out. The contact form on medspaamayhem.com goes straight to my inbox, and you can plug in MedSpa Mayhem or drkated.com and you'll find me. Look forward to hearing from you. This is MedSpa Mayhem, the podcast all about the chaotic world of medical aesthetics. From Botox to lasers to IV bars, learn how to tell real versus fake, legal versus illegal, and safe versus potentially deadly. Hear the crazy stories inside the med spa world and find out what questions to ask and how to spot the people cutting corners. I'm your host, Dr. Kate D. Together, we explore the wild west of medicine that is the aesthetics industry. Hi, this is Dr. Kate D, and I'm back today with Dr. Dahlia Rice. She is a board-certified plastic surgeon, originally from the Chicago area. She attended Colorado State in Fort Collins, Colorado for her undergraduate and master's degree, and then Rush Medical College for her MD. And then for residency in plastic surgery, she did general surgery for 3 years at Michigan State, followed by an integrated plastic surgery residency at the University of Rochester. So that makes 11 years from med school through residency. So congratulations, Dr. Rice, for having done all that.
Thank you. It's lovely to be here. I appreciate you having me on.
Yeah, thanks for coming on today. I was hoping that we could talk about your experience with dermal filler, the good, the bad, the ugly, the things that have gone wrong, and generally what you do about that. So can
Absolutely. I
you
would love that.
Yeah. So can you tell our audience, first of all, what you do in your practice and in all the breadth of things that you're involved with now?
So I own an aesthetic practice in Chicago, Illinois. It's a small little boutique practice that my goal is to provide exceptional patient care to my patients. I do general plastics. So I reach all the way from Botox fillers to major surgeries, including mommy makeovers, breast and body stuff, facial plastics as well. So I love the mixture of everything. And so I love the idea of also taking care of people from all different ages and walks of life. So for me personally, that was my goal. Opening up my practice was to create this boutique concierge level practice in Chicago.
Cool. So one quick question I wanted to ask you, and that is you're a plastic surgeon, so a general plastic surgeon trained. And we've talked on this podcast a couple times in the past about the difference between what a plastic surgeon is and does versus a cosmetic surgeon. Would you be willing to just briefly describe that so people understand that? I know we've talked about it, but it would be really great coming from an actual plastic surgeon.
Yeah, great question. Thank you for asking that. So I'm a board certified plastic surgeon. So the American Board of Plastic Surgery is really the only board in America that certifies surgeons in the cosmetic realm. So when we're talking about the American Board of Cosmetic Surgery, this actually is not a board that has qualifications, certifications as far as the amount of stringent training that is required to become a board certified plastic surgeon. A lot of times these augmented or shortened versions of training are taken on by other people, but it is not technically a overseen like
Right. And it's not recognized by the ABMA, right? Yeah. which is the American Board of Medical Specialties, ABMS, I should have said. And so that's this overarching board under which all of our other boards operate. So if you go to that website and you look up somebody's board certification, there is essentially no such thing as a cosmetic surgeon, right?
Correct.
Yeah.
It is very much used to confuse a lot of the patient population so that again they portray themselves as plastic surgeons and cosmetic surgeons when the reality is a cosmetic surgeon is not a true board certification.
Right. Okay. And I think that's very helpful. There's a lot involved there, and people who call themselves cosmetic surgeons are all over the map in terms of what their actual training is. But the important thing is to know if you need plastic surgery, you really should go to a board certified plastic surgeon. So, anyway,
Correct.
so I was hoping we could go straight to dermal fillers and talk about your approach to dermal fillers and what you do use them for. And then also get into what are the complications of dermal fillers that you've seen and what you do about them. So can we start on the good side and let's just talk about like how you use them and your approach?
Yeah, I think it's so funny because a lot of people think of dermal fillers as purely for an aesthetic reason from a cosmetic standpoint, that they don't maybe like their wrinkles or they need volume replacement and things like that. So when we're talking about volume replacement in intrinsic aging, a lot of times we'll use dermal fillers during these times. However, it is common that I'll sometimes use them in reconstructive surgery too. Whenever
Mm.
I do lip reconstruction, there's some asymmetries that are oftentimes present on that. So I will use dermal fillers in reconstructive patients as well to help create that symmetry after surgery.
Okay, that's really interesting. I assume you're also doing the kind of more, I can't say traditional, but what the rest of us use for primarily cheeks, I would say, and a little bit of lower face is what we use them for.
Correct.
Can you comment on when you actually use them for lower face? Because so the way I talk about it to patients is that people are often pointing to wrinkles in their lower face that they want filled. And really
Mhm.
what's happening is as you get older, you have a couple things going on. So your skin is thinning out, so it's a little more lax. And then also you lose volume in your cheeks. And so you have less support holding up your face. And so your skin kind of is slowly falling down. So your upper face is sort of falling down into your lower face. So actually, you have too much volume in your. I'm using my own face because I'm 56 and I have a little bit of this going on. So actually, we generally start with cheeks, augmented cheeks, and that actually really improves the kind of triangle that is more beautiful. And then I try not to add very much volume, if any at all, in the lower face because you already have too much volume there. The idea is to lift everything. So we do cheeks and then we do skin tightening. We tend to not do a lot in the lower face. Can you comment on any of that?
Yeah,
Right
I
to you?
think from a surgeon standpoint, looking at the whole face as far as from a facial balancing perspective, that's my take on things because really everyone's anatomy is so unique and what they may or may not need or the things that bother them. And for one, I try not to instill my opinion as to what I think they need. A lot of times they'll say, well, what is it that you're interested in? And so you'll find that they'll point to certain areas of their face they don't like, maybe around the mouth area. A lot of times people will be pointing to this, I'll be going to this. And I say, no, that's not filler, right? That's more of a surgery thing as far as from a laxity standpoint. Super common that a lot of times as we're aging in our late 20s, early 30s, we start to lose that elasticity in the skin. The skin thins out, like you discussed, and we get that kind of jowling area. But that happens very quickly. By the time you're 40 years old, you're already oftentimes seeing some pre-jowling sulcus area. A lot of times we're losing our bone mass. By that time, it's already getting to that point, which seems like rude, right? At 40 years old, I should not be having to deal with these things. And not only that, but as time goes on, how do we bridge people to those who are interested in having surgery at some point in time in a safe way as well? So a lot of times I will focus a lot on the cheek area to lift that area up. If someone has a retrusive chin, it can make the jowling sometimes look worse. And so sometimes bringing the chin out to a more profile and then doing a little bit of a touch of a filler into the pre-jowling sulcus area, or even sometimes back here can make a big difference. But again, we're talking small volumes. The skin is
Mhm.
thin here. We don't want to be going crazy and adding a lot of volume to the lower face because then that creates the proportions that can be off at that point. But I agree with you. Focusing mid face tends to be the area where a lot of people want to focus on, or in the lip region, because people tend to hate the perioral region as they get older.
It is a little stressful seeing the little lip lines show up, even though never been a smoker. I don't use straws much like that. Yeah, it's a little painful.
And you can't get away from that, but
Yeah.
still beautiful.
So, can you describe some of the filler complications you've seen in your practice? And then what were the issues? And then what did you do to fix them?
It's a great question because a lot of times when we talk about complications in surgery and from a filler perspective, there's two different flavors because a lot of times people say, well, as talk about it as a complication, but it's truly more of the fact that they don't like the way that it looks. Okay. It can sometimes look
Yeah.
overfilled or there's asymmetry. Sometimes they'll have delayed onset nodules that can form, lumpiness. They don't like the way that feels when they're talking, moving, and animating. Sometimes that is a problem. So those are the things that I probably see the majority of people complaining about, or just the aesthetic of it. They don't like the way it looks anymore, or maybe it's settled in an odd place. And so they want that fixed. A lot of times when we're talking about true complications, this is where we start to get into the nitty gritty of stuff. As far as the most common complication from dermal fillers is skin necrosis or vascular occlusion that can occur in this. When we're talking about the FDA database, the MOD database, and they did a report on how of these complications that they're seeing, over 43% of these are serious complications, which are primarily skin necrosis based
Hmm.
and vascular occlusions. And so those can be quite dramatic and can actually cause blindness and even strokes and death in some people. Although, albeit this is extremely rare, that is something that thankfully I have not seen. However, a lot of times, whenever there's modeling of the skin or any concern for vascular compromise, that's definitely something that obviously most people be concerned about, but really having that education and the awareness to know that's actually what's going on to correct that. But back to your
I
question, the majority of those people I do see are primarily for a cosmetic aesthetic point.
Yeah. So let's get right to that. It's around 50 cases of blindness reported in
Hmm.
that. So for our listeners, it's a very rare thing, but the arteries in your body and in your face in particular connect with each other. And so the artery that goes to your eye, your retina, that allows you to see, actually has connections with other arteries in the face. And so if you hit one of the branches of the facial artery, for instance, it can go all the way to the wrong spot and actually block the blood flow to your retina and cause blindness. So there's actually
Hmm.
somewhere around 50 cases of that reported. So very rare considering how much filler is going into people, but it's
Correct.
something to keep in mind that's possible. So there are
Absolutely.
treatments for that. It's very difficult. You have to be, I mean, so I have two oculoplastic surgeons that I'm friends with that I really care very much about and maintain my friendships with them. God forbid
Yes.
this were to ever happen. They can do a retrobulbar, so basically behind the eye,
Hmm.
injection of hyaluronidase to try to dissolve that filler and fix it and save your eye. That has to be done right away. And so one of the things I think that people don't realize when they're going in for filler is not just that they can have a vascular occlusion, and they have to understand what that means. And that could mean risking your skin, but also
Hmm.
also the risk of blindness. So you want to make sure you're
Right.
going to a place that's not just legitimate, but really is prepared to deal with the disaster were it to occur. So anyway,
Correct on that. And recognition is key. Early recognition is really what, all these case studies have saved people's
yeah.
vision.
But
And some people
also
don't.
not taking the risk in the first place. I mean, there are
That's
places
right.
that I will not inject because it's just too risky. For instance, the
Hmm.
glabella. So we put Botox,
Right.
right, in the 11s, but we will not put
Right.
filler there. And I think that it's just a very risky area because of those connections with the retinal artery. And so we just won't do that. But a lot of places are just throwing filler in willy-nilly because they don't even know that it's a risk or, oh,
Right.
it's not likely, so it's not going to happen to me. But like when it does happen, there's no fixing that. Anyway.
Right. And some of it's cultural too, because culturally there's different facial features. And in general, that's why we tend to see a lot more patients that have issues with blindness and glabellar filler in the Asian population from a non-surgical rhinoplasty perspective to create that contour. And so that does place in a riskier population because of their native anatomy.
Yeah, and to go into so a non-surgical rhinoplasty means Putting filler in your nose to try to change the shape of your nose rather than doing
Right.
surgery. And I won't do that either. I find that to be extraordinarily risky, not only because of connections with other areas, but the tip of your nose has a blood supply that's very tenuous. And
Mhm.
if you lose that, it's much easier to lose the tip of your nose than anything else. That's why people who get frostbite, they lose the tips of their fingers and the tip of their nose. And so
Mhm.
if you mess with the arterial blood flow to your nose, that can be quite a disaster. So that's another thing. If you go to a place that's throwing filler willy-nilly into noses, I think that's insane. I have one ENT who specializes in that here in Seattle. And anyone who ever asks me about it, I send them to her because she does it under ultrasound. She's the expert. Plus, she's a surgeon. She can fix it. God forbid someone
Right.
needs an emergency surgery to fix it. She can fix it.
Right.
In my opinion, no one else should be doing those really at all, unless their best friend or spouse is a ENT surgeon.
I
Even
think
then,
knowing
that's,
your
you know,
anatomy and knowing how to safe injection techniques, using an ultrasound, all these things are super helpful. But just like everything else, complications happen even with the safest techniques, even with the best injectors. Knowing those risks, knowing how to treat them right away in a timely manner and fix any complication that potentially can come along the way is the most important thing.
yeah. So tell me about some of those more minor complications, that the ones where someone comes in and says, I got injected elsewhere and I just don't like it.
A lot of times in the Chicago area, I do tend to see a lot more radius. And so that tends to be a little bit more of a challenge. And we could talk about that as well. But when we're talking about fillers placed in incorrect areas, or maybe they don't appreciate kind of the thinness in certain people's skin in some locations. So some of it can be injection technique, some of it can be the person's own anatomy, because sometimes that can be tricky too. Other times, this can also just be preference, right? Some people are like, you know what, I really don't like the way this looks, even though that may be that injector's aesthetic, right? And so a lot
Mm.
of it is personal preference, and or maybe they don't like the way it changes their face in ways that they didn't expect. And so that
Mhm.
can be pretty stark for some patients, especially when we're talking about, again, a lot of rhinoplasty based stuff or non-surgical rhinoplasty. Changing the nose can change the face profoundly. And that definitely
Mhm.
can make a big difference when we're talking about that. However, I would say the majority of people I see tend to have either migrated filler around the lip area, or the people have radius put in their jawline. They don't like it. And so then when they're biting, then they get sort of these like fins almost that are on the skin that will pop out because it's placed too superficially. And this
Yeah.
becomes challenging because when you're talking about treating fillers that we're placing correctly or in a location that the patient is not happy with, that can be challenging if we're talking about fillers that we cannot dissolve.
What do you do? Let's say it's a hyaluronic acid filler, it's dissolvable. What's your approach?
So I use ultrasound guided techniques for both my like vascular mapping for when I'm doing my injections, during the injections, and or when I'm dissolving filler. So it's super common that I'll see people who come in who have had many years of fillers, all in different layers of their tissues. Because over time, as migrated, they don't even know half the products they've had. But on ultrasound, you can actually detect the difference between hyaluronic acid and some of the other, and then the non-hyaluronic acid based temporary fillers as well. But typically with the hyaluronic acid, you can see that on the ultrasound. I'm able to guide my injection technique directly to that. I can make sure that I get, because there's almost like a pseudocyst that forms around that, or nodules that can happen. And so you have to be able to get through that capsule in order to really dissolve and get that hyaluronidase, or the which is an enzyme that's you break down the cross-linking that's in hyaluronic acid. So that hyaluronidase works pretty quickly, and almost
Yeah.
immediately you'll see some compression of the filler component. We'll massage it, but a lot of times it'll continue to work over the following week. And so I will
Mhm.
sometimes have them come back if they need additional dissolving of their filler. But typically that's my go-to. I think ultrasound guided definitely makes it a little bit easier to be able to visualize where exactly you're placing that product, because otherwise you're just sort of flooding the space and hoping for the best.
So you were telling me before about a patient who was like this, who you basically said, all right, she wanted more filler. And you're like, yeah, no, what you really need is dissolve all that and start over. Can you tell that story?
Yes. So I had a patient who came in wanting more lip filler. It was asymmetric. She had some lumpiness to it. She wanted that fixed. And so when she came in, she goes, all right, I want a syringe of filler to refill and correct those areas. And I said, nope, we've gone too far at this point. She had some migration issues. She did have some nodules. And so whenever I see those things, a lot of times it's best to just start from a clean slate. We dissolve everything and then we start over. And so then we can also at that point target our refill when we're doing the hyaluronic acid after we've dissolved into the areas that we really want them to be. And then also less volume, because at that point, when you're not trying to correct something with, the problem is if you're trying to correct with hyaluronic acid a defect that was caused by hyaluronic acid, you're essentially chasing your tail at that point.
Yeah.
But the problem is sometimes people don't feel comfortable enough to be able to dissolve fully and start over. And from a patient perspective, that can be shocking because the deflation that can happen afterwards, people are like, oh my gosh, this looks terrible. And so that is something that you really have to guide your patients with and tell them that this is a journey. We're going to go on this journey together. It could be a month. But again, starting from a fresh slate is going to be so much more important than trying to add on top of the mess that's already there.
Yeah. How long do you usually wait after you've dissolved and you put in the Hylenex in there? How long do you have
So
to
I
wait before
will
you start filling again?
That's a really good question. And I think a lot of this is very surgeon dependent, but in general, they say that the mechanism of action of the hyaluronidase is about a 24-hour period. Although I do see that within that week, some people will continue to get more resolution of their filler that gets reabsorbed. So I'll have them
Mhm.
oftentimes come back every week. And then when we're at a point where we're like, we like this, looks great, we're happy with where everything is at, you don't have to dissolve everything 100%, but the majority
Mhm.
of the areas that are not anatomically pleasing or they're in the wrong location or whatever you want to call it. But at least in that respect, once that's done, a lot of times I'll wait 1 to 2 weeks, depending on the patient, to let everything settle out, let the swelling go down, and then to see where we are at our base point for refilling. And some people choose not to refill, and that's okay too.
Yeah, well, it sounds very reasonable. I find that some people are just overstuffed. And I've always thought of that as really being primarily because of the incentives in our business. I mean, not everybody, but injectors who are incentivized to inject more, so they make more money. If you walk in and you're willing to pay for 4 syringes, they'll inject four, even if you really don't need four. But what do you think? Why do you think that people are out there walking around looking like super odd and overstuffed with too much filler?
I think that's such a great question because a lot of times people will scratch their head and think, what was this? What's this person thinking? Do they not even recognize that this is how they're looking? And I think that
Yeah.
this is really a multifaceted situation. I definitely agree with you that incentivizing syringe cost and things like that, the more you sell, the more you make sort of situation makes
Hmm.
it a little challenging because you're doing a fee for service, right? I'm not buying 4 coffees. I'm buying 4 syringes that I'm asking you to inject in me. And really it comes down to the provider and people who are making poor aesthetic decisions based on monetary value and or this is what the patient's pushing for and the patient wants it and therefore they'll do that.
Hmm.
Then I think that's a huge culprit because it ultimately it falls on my shoulders to say absolutely not, like we are not getting to that point, or if we do that might lean you towards an unnatural look. And nowadays, I think that the trend of these over exaggerated features are sort of becoming less trendy now. People want more natural results. They want more subtle results. They don't necessarily aren't necessarily looking for that over exaggerated component. However, I do think that there is some element of creep that happens, right? This whole like concept of perception drift, or if you change
Hmm.
little bits at a time, that slowly that becomes your new baseline, and then you're chasing the next. And next thing you
Yeah.
know, you don't even recognize how that alters your features over time. And I do have people sometimes come in and say, I just woke up one day and was like, oh my gosh, I look crazy. Like, this is just, how did I get to this point? Right. And so no one is immune to this concept. And I think the biggest thing is, again, look at your injector, right? Look at the person who is doing those things, who you are choosing to go for as your provider. If that is a person who you're like, I don't want to look like that, then don't go to them because
For
everyone's
sure.
aesthetics is completely different and a fit is super important between patient and provider to be able to meet on the same aesthetic level and understanding. Because if someone comes in and they want a very overinflated look, I will kindly decline and say that's unfortunately just not my aesthetic or my preference, and
Yeah.
therefore I won't do that.
Yeah, there was so as I've said on the podcast a few times, like I have no filler in my face and I'm very conservative with filler. I think it's reasonable when you've got like divot and you fill that divot, it looks amazing. You're putting volume back where you lost it and it looks good. If somebody doesn't have any volume loss, they definitely don't need more volume. And so now you want to look like somebody else. And I do think that over time, well, I guess you can start looking like somebody else, but I just most people in my area are really not interested in that. Most people in the Northwest is very natural, crunchy here. We are a lot of campers and hikers, and people are out on their boats and kayaks, and people really want to look natural. And I do think that because our aesthetic at my place, we that's our aesthetic. I think that's sought after, at least for me. I have to say that there was an injector, a doctor actually nearby who she's not here anymore, but she was new and a few people who had gone to her took one look at
Mhm.
her and was like, "Ah," and,
Mhm.
and I heard about it afterwards, right? I didn't want her to inject me because she's too
Right.
freaky looking. I do think that is a good red flag. If you don't like the look of your injector, I would probably
Right.
not get injected by them. But I definitely have seen injectors where they're basically, they're nurse injectors in places where they're highly managed by administration who are asking them for certain revenue quotas and incentivizing them to do more per hour. And when you do more per
Mhm.
hour and you generate more per hour, you generate a higher income for yourself. And I've seen a lot of these people who are beautiful and young and probably don't even need filler at all, but they're injecting a massive amount of filler. And I also
Right.
think that a lot of those people, that's their main tool is injectables. So if they don't inject it, then that's not something they're going to do themselves and that's not something they're going to make money from. Maybe they don't have any lasers there, or maybe they don't have any RF microneedling or other tools that we use to do skin tightening. And so they have
Mhm.
one tool and they're going to use it. And I don't necessarily think that a normal unstuffed, unfilled injector doesn't mean that they won't slam too much filler in you.
I think you're right. A lot of this just comes down to ethics and what the focus is. If the focus then shifts from a patient perspective and what the aesthetic is that's best for that particular patient, but now we're focused more on a monetary compensation value system, then of course you're going to end up having more. I think that the some of the companies are starting to also pick up on the fact that they're getting a lot of overfilled patients. And so some of the syringes that we're finding now for certain areas, like the tear trough, for example, are only in 0.5 cc's instead of one full cc, because then you're selling the syringe, but at the same time, the that sort of risk of wanting to use the entire syringe, it helps remove some of that aspect of it. Although I think that when it comes down to it at the end of the day, incentivizing a number definitely puts
Yeah.
people's focus on a different aspect.
You mentioned Radiesse earlier and I made a face. Can we talk just briefly about Radiesse and Bellafill? Because they're very different from each other. And I do think
Right.
some people are using hyperdilute Radiesse as a biostimulator. And maybe we can come back another time. We can talk about biostimulators. That's an interesting
Yes.
topic. But
Hmm.
I'm talking about its use as a filler, and it is not dissolvable. It's made out of calcium hydroxyapatite, which is calcium, and that's what your bones are made out of.
That's
And
right.
so Hylenex does not dissolve Radiesse. And then Bellafill is one that's basically made out of little plastic beads. So can you say, because you said that in Chicago, a lot of people are coming in having had Radiesse elsewhere. So what are you seeing with that? And what do you do if you need to dissolve Radiesse, or what's your approach?
Yeah. That's a great question. And I think I've noticed, and this is of course anecdotal, that the a lot of times when I'm talking to my colleagues or other surgeons, other doctors, they do tend to, from a surgeon's perspective, don't use as many permanent or non-dissolvable fillers. Okay, so the FDA approved dermal fillers back in 1981, but the only filler that is permanent is the PMMA or those little plastic beads that you're talking about. These other dermal fillers that are temporary, which can stick around for a few years, but are not dissolvable. So anything that's not hyaluronic acid is not going to be able to be dissolved. And so when people come to me and they say, "Oh my God, I had this radiesse put in my jawline. I don't like the way this looks," a lot of times there's two options at that point. One, the obvious option is just you have to wait, right? You just got to wait it out. And so then within a year, 18 months or so, it gets a lot better. But a lot of times patients don't want to wait that long, or it's in a bad location, or they have a very obvious nodule. And so the other things, and there's not great options for this. And so the most common option out there that people talk about is causing a hyperdilute space where the radius is basically flooding the area with a bleb of water, sterile water, or saline, or something along that. Even hyaluronic will sometimes use, even though that does not actually break up the radius. And then what they'll do is they'll mechanically break up those clusters or the product that's in certain spots. Now, those
And
are
how do you
that's when it's
how do you
fairly
do that?
early. Massage. You got to aggressively
okay.
massage. Yep. You place the bleb and then you aggressively massage. Now, you're not getting rid of the product. You're just spreading
Right.
it out into the tissue, right? You're just
Breaking it up.
right. You're just creating a more smoothness there so that hopefully it doesn't create too much fullness into that area.
Does
And there
help
is
it
some discussion on that.
does that help your body resorb it a little quicker then if you spread it out like that, or no?
The theory is yes, because basically then that creates larger, like product globules that your body needs to break down over time,
Mhm.
which conceptually makes sense. However, they're doing all kinds of studies now and seeing that on X-ray because it is calcium based, like you talked about, like in your bone. They can see that on X-ray. They can
Mhm.
see these things on MRI. And so we're seeing what we originally had thought about what are temporary fillers are seeing years and years down the road in these MRIs now, sometimes 10 years later. And so I think our perception as to how long these truly last is shifting
Yeah.
quite a bit.
Well, and I've seen studies looking at MRI from people who've had actual hyaluronic acid fillers in the tear troughs, but they were placed too deep. So there's
Mm-hmm.
a septum there. So for our listeners at home, there's a septum there that kind of separates your eyeball and everything behind in your orbit and like the skin and your lids in front, right?
Yes.
And there have been studies showing that people put it too deep behind that septum and it's there for a decade or more. So there's a
Mm-hmm.
one MRI study that I saw a while back that showed that. And you can't dissolve, I mean you like dissolve and dissolve, but you're never going to get back there. And so that to me was really interesting because we think of hyaluronic acid as very temporary. Your body breaks it down. So if your bloodstream can get to it, your body's going to break that down within
Mm-hmm.
about a year. Depends on how much blood flow it gets. But if it's in a space where
Right.
there's really no blood flow, it's not going anywhere. And so for that reason, actually, in my practice, we've completely moved on to using PRFM for tear troughs and very rarely do filler anymore. It can be done and we do it very carefully, but
Mm-hmm.
for the most part, we don't recommend it anymore. I'm curious to know if you ever do tear trough filler, or if you how you do that, or do that under ultrasound?
Yeah, so that's a great question. And I do oftentimes I will do tear trough fill. A lot of it depends on the patient's anatomy. If they're coming in and they have bags under their eyes, festoon, that line, that circular line that happens, like the cat's out of the bag. Okay, that's surgery all day long. No filler is going to help that. In fact, filler
Right.
sometimes can make it worse because just like you're
Yep.
saying, they can get in behind that septum. And once they cross over that threshold, that creates more bulging into that area. So the exact reason they came in that they didn't like is now worse. And so, knowing what's a patient that's a surgical from a tear trough perspective and knowing who are the people that we can somewhat bridge. And the people that I tend to see that do the best with tear trough filler are those who are in their kind of late 30s, 40s ish age range where we start to lose volume around the eye area. Again, very small. We're not
Mhm.
talking about large amounts. And I oftentimes will use an ultrasound to map out the vessels and or do them under ultrasound guidance to ensure that we're not getting into any of the vasculature.
Right. And also, I think, again, for our listeners, I'm always pointing out, like, how do you know who to go to? I don't like my under eye area. How do I pick a provider? What we're talking about here are all the reasons why you need somebody who knows what the heck they're doing, not just somebody who's got a syringe of filler in their hand, because it
Right.
really matters. Tear troughs are really delicate and dicey to deal with, and you
Mhm.
really need to know where you're placing it and what you're doing and what the risks are and how all the different people look different, their anatomy is different, what's going on with them is different. Can't treat them all the same. So it really matters who you go to for that.
So I oftentimes will use that as a bridging agent. However, there are times that people have come in, they've had lots of filler in that area, creates that lymphedema or the swelling that happens into that area. I know we talk about that a lot with some of the celebrities that we see, and that's always a hot topic. But really, the reality is this happens to everyday people too, and that can happen over time as well. It's not something
Mhm.
that can always happen immediately right away. It can happen years down the road. I mean,
Yeah.
we're coming up on 20 years of hyaluronic acid filler anniversary. And so this is somewhat of a also a generational thing too, right? We sort of created this whole environment where it's been so many years and years of fillers that we don't even know where they are anymore sometimes.
Yeah, I think there are people who've come into my place where they've had filler for so long, they don't remember what kind, they don't really know where. And some of them keep track. I had one lady, this is years ago, I just adored her. She was hilarious, but she had been to a previous place that was a Bellafill place. And she had
Mhm.
what she said was at least 75 syringes of Bellafill over the years
Oof.
in her face. I'm like, oh my gosh.
Oh, wow.
And it was weird because you couldn't really use a cannula on her because she was
Sure.
so blocked up. So for people at home, cannulas are these little tubes that we use rather than needles sometimes, and they flow through the subcutaneous tissue. You have to direct them, and Bellafill acts like you just gunked it up with
Yeah.
some like really sticky gum, like you can't get it
Mhm.
through at all.
You're absolutely spot on about that. I
Yeah.
mean, the fibrosis of that scar tissue that be created in some of these different products can be a problem because when you're talking about later in life wanting to have a surgical procedure, your risk of complications is increased, right? And because you're creating scar tissue, the more scar tissue you have, the more likely you're going to get nerve damage, or it will increase your risk of complication from a nerve damage perspective and or other structures that can get damaged during a facelift, for example.
Yeah, and so that was my next question. The question was going to be of all the things that we put in the face non surgically, are any of them concerning to you long term with facelift? So, I obviously Bellafill is one. The other one you mentioned was Radius. So, does Radius ever interfere with like a facelift, or is it really not that big a deal? And then the
I
last
think the
thing I wanted to ask you
companies,
about was
Mhm.
Sculptra too,
Yes.
because I've asked
Yeah.
that question to other plastic surgeons. I'll tell you what my answer is that I've gotten, but I'm curious to know
And
what you
I
think about
I
Sculptra.
feel like people either love Sculptra or they don't. And one every person is totally unique. And so there's specific fillers for certain reasons that work great for certain people. Like I think you're correct about the Bellafill. We do see a lot of scar tissue with that. It is FDA approved, one of the only fillers that's FDA approved for acne scarring. So it can be really helpful with those patients.
Yeah, and
However,
I have to say I've seen people where cosmetically you can put Bellafill in an acne scar and improve it, but one of the worst festering infections I've ever seen was from that very thing because it's
right,
plastic and it acts as a nidus for infection. I don't like it for that either. I'd
right.
rather do
Again,
RF
the
microneedling and then Sculptra for those people rather than putting Bellafill in there because Bellafill just
right.
if it gets infected, forget it.
Right. And that's the thing is people can have allergic reactions too, because based on the recombinant component to it, that can create a problem as well, whether it's an animal product or a human recombinant product. But you're correct. And the companies will often tell you, no, this doesn't cause scarring. Oh, not at all. And some of it can be related to a dilutional standpoint. So we saw a lot more issues with scarring and issues with Sculptra when it was diluted at a more higher concentration than we see now. Now that it's becoming a little more diluted, we know way more stuff about fillers than we used to. And so we have some of the evidence now to back us up on what is the appropriate amount. But I will say that sometimes when I see people who've had many fillers over the years, even if it's been a decade or more, you will oftentimes see like some of the planes just don't want to dissect properly. They're very
Mhm.
sticky. And again, a lot of these people have been getting Sculptra for many years, Radius for all the years. And again, a lot of it depends on the person and depends also on the injection technique. Because if you're in the wrong plane, sometimes it's not easy to identify. And that can create scar tissue in a plane that you are not necessarily intending to place your product in.
Mm,
And so I think that can be more of an issue as well.
interesting. So I've asked that question because that's come up with patients because we love Sculptra. We get really great results with it. And I had a couple people ask, well, if I want a facelift 10 years from now, is this going to matter? Is this going to cause any scarring that's going to make that a problem? And I've asked a couple of plastic surgeons, and both of them were like, "Oh, no, it's no big deal. Not gonna
Yeah. And I
stop you
think,
from having the surgery. It's really not that big an issue." And
yeah.
y
And it depends on the patient too, because some people
mm,
scar great and not issues. Other people are terrible scars,
sure,
right? So some genetic component is a huge component to that too, because how aggressively you mount an inflammatory response to some of these things can
sure.
dictate whether you're going to have all that scar tissue or not, and or where the injections have been. But overall, as plastic surgeons, we're also used to that, right? Because not a lot of people are going to walk into my office wanting a facelift who've never had anything done to their face before. It happens. I've definitely done those. However, I would say that's probably less common. And I think a lot of this also has to do with just our knowledge and the length of time that dermal fillers have been out and trying to bridge. Because also for a long time, people were wanting to wait until they were in their 60s to have facelifts. Now people are wanting them at younger ages because they don't want big, impactful results. They want more subtle results over time. So it's not intense.
Yeah. Well, so can you tell our listeners the name of your practice in Chicago in case anybody's in the Midwest and wants to visit you? And then I was hoping you could leave us with any advice you'd like to leave our listeners with at the end of this.
Yeah, thank you so much. My practice is called DMR Aesthetics, and I'm in Chicago. I'm in a neighborhood in Chicago called Wicker Park, and that's west of the downtown area. But these areas in the city in general, they're little pockets, little neighborhoods, and being in a location that's easy for people to access is super important to me and my patients. From my standpoint, again, really focusing on the patient experience is super important. From the listener's perspective, what are the things that you should look for to make sure that you're safe and that you are choosing a good injector who has the proper credentials is super important. So do your research. Research the med spa that you're looking at. Research the injector specifically that you are working with. Look at who the medical director is. Is that medical director there all the time or are they not there all the time? Because sometimes they can be in completely different states. And so if something
Mm,
happens, how are they going to fix that, right? In the settings where complications can occur and that can be increased risk of complications with people who don't have as much experience in injection techniques. But really overall, a lot of it will be that whether there's complications that happen, because who's going to be there to help fix that when that happens, right? And those are very good questions to ask. You can also ask, where do they get their products from? Do they buy them directly from the supplier or do they buy them from a third party place? Those are also very important questions. Make sure that you're seeing the packaging. Make sure that you're noticing if the packaging has any abnormal wording that doesn't make sense or other languages. And so this should be pretty obvious, although they are very good at making sure that it looks pretty similar. So you got to be very good about that. And don't be afraid to ask for that packaging. Don't be afraid to ask for them to, if you're getting Botox, for example, to mix that up in front of you. So those are all fair questions to ask. And I think the other thing, again, I want to reiterate is fit, right? You need to choose an injector, a provider who is a good fit for you. So that not only does your aesthetic goals align, but you can know what to expect then at that point, because you can say, okay, I like that aesthetic look of this provider. I've seen her work. I like that. And I think asking for before and after pictures is very good, although sometimes we just don't have them because people are very sensitive about putting their face out there.
um,
But really, the reality is that you want to make sure you vibe with that person because at the end of the day, everything goes awry. You want to be able to trust that person's got your back and that they have the education, that they know exactly what to do at the right time and aren't dismissing what your concerns are or whatever. And so I oftentimes over communicate with my patients and tell them, you're going to expect this, right? You're only going to remember maybe a quarter of what I said. However, we're going to reinforce those things. So I oftentimes have them come back and then talk to them. Hey, are you having any concerns? Please send me pictures if you have any concerns, because it's not uncommon that sometimes at 1 week out, people can get lumpiness that then resolves over the next week. But
mhm.
if they didn't reach out to me and ask where they didn't feel comfortable doing that, they may not
Right.
know the right thing to do.
Yeah, you actually absolutely have to feel comfortable and be able to trust your provider. Well, Dahlia, thank you so much for being here today. It's been great talking with you.
Great. Thank you, Kate, so much. It's been a great time. I really look forward to coming on here again.
That would be fantastic.
Awesome.
If you've learned something and like what we're doing, please tell your friends and give us a 5-star rating in your podcast app. If you have a question or a crazy story of your own you'd like to share, please send an email or voice recording to info@drkatedee.com. That's DRKATEDEE.com. Or reach us through the website, MedSpaMayhem.com. And read the book. MedSpa Mayhem is available everywhere books are sold. Thanks for listening. This has been MedSpa Mayhem with Dr. Kate D. We are so grateful you're listening, and we hope you've learned at least one fun or possibly disturbing fact today. Don't forget to hit subscribe on your podcast app and leave us a 5-star review. And read the book. MedSpa Mayhem is available everywhere books are sold. Links and more can be found in the show notes and on medspamayhem.com.